So welcome everybody to the Coffee Cases and Controversies for our October event. Let me do a little introductions here about who has joined us today. Starting with Dr. Gautam Kumar. He's an associate professor in cardiology at Division of Emory University in Atlanta. He's also director of echocardiography in Atlanta VA. He has a great experience in high-risk PCI, CTOs, hemodynamic supports, pulmonary embolism, as well as robotic treatments. Dr. Goran Oliver Krona from Sweden is a professor and a senior consultant at the Department of Cardiology at Skane University Hospital in Lund, Sweden. He is a world-known interventional cardiologist. Dr. Ahmed Magdi, who really doesn't require a lot of introduction. Everybody in the world knows him. He's the chairman and founder of a Combat MI program. He's the past chairman of cardiology at National Heart Institute in Cairo. He is part of multiple boards as well as trustees, previous trustee of SCAI, and he's now an international ambassador for SCAI. He's also part of the directorship of the C3 Congress. Dr. Dimitrios Nikas, he's also a consultant and professor of cardiology at Ionias University in Ionias, Greece. He's a phenomenal interventionalist and does a huge number of complex PCI as well as structural heart cases. Dr. Parag Doshi is the founder and president of Chicago Cardiology Institute. He's a course co-director for C3 meeting, and he's worldwide known for his CTO expertise and provides instruction to thousands of CTO operators over the world, including the US and Japan. We have Dr. Jaideep Chakrabarty from Duke University Medical Center, who's recently written extensively regarding robotic PCI. And we're waiting for Dr. Ehtisham Mahmud. He's have joined us now. He's a professor and division chief of cardiovascular medicine at University of California in San Diego. He's really our distinguished guest today. He's also been a previous president of a Society of Coronary Angiography and Intervention, serves at multiple committees of a variety of different organizations. He's on an editorial board of Circulation, JACC Interventions, as well as Structural Heart Journal. He's well published in the field and well known world over. His research interest includes robotic PCI, and that's the area of discussion today. Gautam was about to make some general comments. Gautam, go ahead and make some general comments about why robotic PCI is important, and then I will turn it over to Dr. Mahmud.
Perfect. Thank you very much, Raj. Again, this looks like it's going to be a great session. Well, robotic PCI versus regular PCI. I think that's really the big debate here. And, we've heard controversies as well as questions that go in both directions. So in the next hour or so, we'll try and work our way through some of these. Probably the biggest advantages of robotic PCI are, number one, there's less exposure to the radiation exposure to the operator in the room, as well as staff, because they're able to stand further back. That's obviously a huge advantage. Less risk of orthopedic injuries, clearly, because you're not wearing lead for such prolonged periods. 3, there's greater precision in delivering equipment. Now, detractors of robotic PCI will come up with, well, it takes longer to set up, it's more inconvenient to set up, you still have to have a tech in the room at all times. Depending on how your lab is set up for the robotic system, and Dr. Mahmud can obviously attest to this as well, depending on how your lab is set up, you may need to scrub in and scrub out multiple times, depending on how the robotic implementation happens in your lab per se. No, so those are obvious issues. But do the advantages justify the cost, and the disadvantages and the benefits? I think Dr. Mahmud, please go ahead, take us through this.
Great. Thank you very much for the invitation. And this is a real pleasure to join all of you, and Raj for the invitation. I think what we'll do is I'll start screen share and put my presentation up. My plan is to first review the data, and then I'll show some cases, and then we'll have plenty of time for conversations about it. So let me just all right, can everybody see that?
We sure can.
Okay, fantastic. So once again, thank you for having me. I really appreciate the invitation. And I am trying to figure out why I can't move my slides forward. There we go. These are my relevant disclosures, predominantly that I received research grant support from Corindus for doing some of the precision studies. Why are we talking about robotic PCI? Gautam just briefly mentioned this. The major reason for all of us who work in the cath lab, and this is a study from Italy showing that over time, especially if you've been working in the cath lab for more than 15 years, whether you're a tech, a nurse, or a physician, you're talking about prolonged risk and occupational hazards of the field. That includes orthopedic risk, and there are some data regarding malignancy risk being increased as well. So what is robotic PCI? The original technology that was approved in the United States was the CorPath 200 system, and now there's the GRX system. The major aspects of this concept is that you can now remotely, not tableside, but control the guide catheter, guide wire, balloon, and stent. And that's me sitting there, and you can see that I have 3 controls. The one on the green on the extreme right is the guide catheter. The middle knob, the circular knob, enables you to torque, advance, retract the guide wire, and one on the left is the knob you use to control advancing or retracting the balloon and or stent delivery system. So some of the other benefits are potential benefits of enhanced visualization and precise lesion assessment. I'll talk about that just a little bit. This is the first version, and I always like to show this slide to make it simplified. This is for the CorPath 200, not the GRX. The red line is where the 014 guide wire that is advanced or retracted goes. The blue line represents the rapid exchange port for balloons or stents. And you can see how it's clamped in. The guide catheter is clamped in after position within the artery. So the PRECISE study was the first study done showing the feasibility of robotic PCI. Just under 200 patients were enrolled in a multi-center format. The vast majority of lesions treated were simple, non-C in that study, but that's the study that got the device approved, FDA approved in the US. We performed this study, the CORA PCI, Complex Robotically Assisted PCI, single center at UC San Diego. And the hypothesis was, yes, we know it can be done in simple lesions, but we wanted to treat complex coronary lesions. So consecutive robotic PCI procedures over 18 months were in one of our labs had the robot. So all cases scheduled in there, ad hoc or planned, were done robotically. And during the same period of time, the patients that were PCIs done by myself were the control group if they were done in a non-robotic room. And this was an all-comer inclusion criteria, and there were no real restrictions. The only restrictions were atherectomy, planned 2-stent approach, or thrombectomy or CTO. So we had 413 procedures. You see the ones that were excluded. And ultimately, manual PCI were 226 cases and robotics was 108. The key point I want to highlight is near the bottom, which is the lesions that were treated predominantly were type B2 or C in both groups. So as I mentioned, the first study that approved robotic PCI was the PRECISE registry. And in that study, B2C lesions were about 32%. In Cora PCI, with robotics, it was 81%, and in manual, it was 69%. Our primary endpoint was the robotic technical success. We also reported clinical success. 82% of the cases were done entirely robotically. 7% required manual conversion, and 11% had partial manual assistance. So, and the partial manual assistance was planned. So technical success was defined as a procedure done entirely robotically or with planned manual assistance in the absence of MACE, and that was 92%. Clinical success in the two groups was comparable, high 99%. One of the points that Gautam brought up was, what about time, procedure time? And when you do robotic cases, it takes longer, and that is true. We looked at that in an organized way, and we saw that it took on average 8 minutes longer to do a robotic case than a manual case. But we also looked at degree of complexity within the lesions, and as the lesion complexity increased, that time delta actually disappeared. So it was predominantly for relatively lower complexity lesions that the robotic time was longer. We also looked at the secondary endpoint of freedom from periprocedural MI, and that was statistically not different in the two groups. This is defined as a CKMB of more than 3 times upper limit of normal. We took an attempt at evaluating resource utilization by looking at fluoroscopy time, dose area product, and contrast volume utilized during the procedures. All of them the contrast volume was statistically significant and lower in the robotic group. The other two showed no difference between robotic and manual. Looking at a propensity matched analysis for procedure time, it came out that it was longer, but everything else that I mentioned from a resource utilization standpoint did not show to be different. So that was a single center evaluation of complex robotic cases. Precision is the first multi-center, 16-center registry looking at outcomes over a 4-year time point. Clinical success was defined as a residual stenosis less than 30%, final TIMI 3 flow without MACE. Technical success, same endpoints, but in the absence of manual assistance or conversion. 754 procedures, 950 lesions. The majority of lesions were done transradially. This was not pre-specified. 60% were done radially, 40% femorally. This particular analysis that I presented at SCAI was comparing outcomes from femoral to radial. And the key point being radial PCI could be done robotically with high clinical success. Because this is not a randomized comparison, I would take the outcome difference with a grain of salt. Technical success was higher with radial, but a subsequent analysis also showed that the lesions we treated radially were slightly less complex. But here's the question. I keep talking about roughly 20% of cases either require some manual assistance or manual conversion. Why is that? So we took a look at that particular cohort of patients, the 18% to 20% that required some manual assistance. And we published the findings here where almost half of them, 45%, this is with the CorPath 200 system, it was because the guide catheter would get disengaged or you needed additional guide catheter manipulation. The other 40% were limitations of the robotic platform, and a few were due to adverse clinical events. That got to the second generation CorPath system, CorPath GRX. What's the difference? The big difference here is the ability to control the guide catheter. So the first generation did not have an ability to control the guide catheter. The second generation does. First single center publication, we did 40 consecutive robotic cases with the CorPath GRX system. Clinical success was 98%. Technical success was 90%. So keep in mind, in the previous generation, technical success was about 80. It jumped up to 90%. And what we noted is out of the 40 patients, only 4 required manual conversion or assistance, and I've got the reasons for those 4 cases listed here. Here's an example of an osteal right coronary artery that we did with the GRX system, and key points being that once you get the stent in an appropriate position, you can disengage the guide catheter, keep the stent in position, and optimally deploy it. And that gets me to the most recent data. I presented this at the SCAI annual scientific sessions this year. This is a study that's in the process of manuscript being submitted. So the 2nd generation robotic PCI system, we wanted to report the final multi-center results. 20 centers, same clinical and technical success definitions. 60% of the cases were done radially, 1.6 stents used per case, total stent length 38 millimeters. And the rest of the areas you can see. Key points being up here that active guide catheter management was required in almost half the cases. And however, the bulk of them were successfully manipulated robotically. We treated the LAD and RCA predominantly. The circ was in 27% of cases, but there were 2% left main cases and 1% vein grafts. If you look at the lesion characteristics, type B2 and C were almost 70%. On average, 17 millimeter lesion lengths and a series of complex characteristics of the lesions treated. Clinical success, high, 98%, and it was similar across the various lesion types. Technical success was 90%, and this is, I think, the key finding of this study. We went from an 80% to 90% technical success with the current generation GRX system, and as you can see, the technical success was higher in type A and B1 lesions at 95%, and a little lower with type B2 and C lesions, just under 90%. There were no significant major MACE events in hospital, but you can see all of the other minor clinical events, both. And then when you look at why did we have conversion and how often did you have conversion, that's on the right side. And I think that's the other very important finding in this study, which is roughly speaking, 5% of the cases, you were unable to advance the balloon or stent, and in about 5% of cases, were unable to cross the lesion. This is amongst the cases in which there was manual assistance or conversion. The outcomes for femoral, radial access, clinical and technical success were comparable. What about high-risk lesions? So here, the data are being reported for osteal left main, calcified, bifurcation, and CTO lesions, and you can see high clinical and technical success. The only caveat for the CTO lesions is that for a CTO to be enrolled in this particular study, you had to cross the lesion first with a guide wire. So this is high CTO success provided manual crossing of the CTO. So in conclusion, what I've shared with you thus far is the majority of robotic PCI in Precision GRX was in type B2 and C lesions using radial access. There's high clinical and technical, 98 and 90% success with the CorPath GRX robotic system. The CorPath GRX system enables guide catheter control and reduces the need for manual assistance. And these data clearly support robotic PCI being a viable option for addressing both the orthopedic and radiation-associated risks for the interventional cardiologist. What does the future hold? I think there's a lot of work that we need to do. First, the telecommunication, if we're going to seriously approach remote robotic PCI. We need an over-the-wire platform to be able to do CTOs and atherectomies. And finally, a second robotic drive for a dedicated approach to bifurcation lesions. So Raj, I will stop there.
Sure.
And, you know, there are some other points, if you want, I can make for a couple of minutes about telestenting and peripheral, or we can have a discussion. What are your thoughts?
Yeah, let's do a few minutes of discussion so that we can break up the session. And then I do want you to talk about a couple of other points that you are mentioning and show your cases. But let's pull in some panels. So I think there is no question that in the history of intervention, you know, we have made a lot of strides in innovating our balloons, our stents, our wires. However, we have not talked, you know, we have not really focused a lot on the operator safety. We have not really focused on the mechanical aspects of the treatment. And, you know, especially now, you know, this has already occurred in the outside of the United States where, you know, the coronary treatment has pretty much gone as an outpatient. Lots and lots of centers worldwide that do coronary intervention. And the cost is a big issue. And I think that something like robotic PCI, and you showed some of this data, you know, the precision becomes very important because if you just add an extra stent, you really minimize your margin now for the procedure, and the center is no longer viable. You know, and I've seen many of these centers closing, you know, internationally because of lack of precision in stent placement. And I think this is something that's going to happen here in the United States as well. So I think this is going to proliferate this technology to improve the precision. And it's nice at age 50 plus, you know, that you don't have to wear lead for the whole case. You sit in a nice chamber and do a case because the tech, I know Gautam mentioned something about the tech, but the tech doesn't scrub in on every case, but you do. And so I think that for them to be in a case, you know, it's not that much of an issue as much as an issue for you because you're going to be scrubbed in every case, you know, so I think that's critical. So I'll open it up for any questions and discussion. Gautam, you have any comments about the data from that Dr. Mahmud just shared with us?
No, I think a lot of my initial comments were based on reading Dr. Mahmud's papers. As you know, he's an expert in this field. Yeah, you know, I think we need to start thinking about how we're going to do things differently going forward. And I think that really is an important message, whether it is with GRX or whether it is with further emerging technologies, some of which Dr. Mahmud alluded to as well. But I think we need to start thinking about what we're going to do differently in terms of protecting operators and protecting staff and improving patient safety. That really is the first message. What do you think, Parag?
So I think this is a phenomenal system. My two key questions, I think the very first one was a little concerned with the contrast volume, actually in both manual and, you know, the traditional and contrast where it was 180 cc, but I think in the subsequently you showed 118 cc. That's good. The CPO, I have a question because it really, the majority of the time is spent in crossing the lesion. And that brings up the third question, that on one hand, we're trying to cut down our orthopedic and cancer risk. But how do you compare it with the new radiation protection system like Rampart, where you don't have to wear the lead at all? So you maintain your manual control, especially in complex lesions like CPO, and yet you don't get the orthopedic and cancer risk to the extent that in general.
Yeah, so I would answer that as saying that you know, each of if the only reason to do this is just for addressing orthopedic injury, then this may not be, you know, this may not be viable in the long run. I think that at the present time, Clearly, that's an obvious advantage that we don't wear lead and we're not getting directly radiated. But there are other alternative technologies that are being developed as well and have been developed. And I think they help synergistically. When it comes to complex lesions, I think it's very important to differentiate the CTOs from all the other complex lesions. For CTOs, yes, you still need to cross the lesion, and we did show feasibility of 10 relatively short CTOs, about 3 centimeters long, that we were able to do robotically, and we were successful, and we actually crossed the lesion robotically, so did not have to scrub table side. But that was a small group. As the lesion complexity increases in CTOs, that ease of use certainly is no longer there. But I think the comment you're making is a crucial comment, which is that if we can't show additional benefits, and I've been thinking a lot about it, patient level benefits. I think there is the concept that remote PCI may help with some benefits in the sense that if you're part of a multiple health systems, you could have a complex operator help somebody who's not as facile with complicated lesions, and that person could be sitting at a distance helping a complex robotic case. So I could see those benefits, but undoubtedly, we need to design and develop studies. And if we want this technology to succeed long-term, it has to have some level of patient benefit. That's my personal feeling, because that's when the payers will step in and start to reimburse. And we need to work towards that, because otherwise there's still this struggle. What do you offer above and beyond, not just manual, but alternative technologies that can help address the orthopedic and radiation risk?
So has ACC and SCI, have they issued any statements, consensus at all?
Specifically around robotics or about occupational hazards?
About robotics.
Neither organization has issued any statement on that. And I'm obviously inherently conflicted. So even my time as SCI president, I absolve myself from any even proposals around robotic PCI that came forward.
So, Shami, how are you? I'm Ahmed Magdi.
I am very well, Ahmed. It's been a while.
Yeah, nice to see you. So let me ask you a practical question. Since you have been innovative and creative about this procedure since almost 15 years. So from your practice, what is the percentage of the patients for whom you are performing the robotic procedures, and which patients you select to refer for this? What is the percentage in your center practically? How many patients or the percent?
Great question. So we have the robot in 2 of our cath labs, and in those 2 cath labs, any patient who gets scheduled, we try and do robotically. The patients I do not do robotically are the following: CTOs, because if I'm going to cross the CTO, as has been pointed out earlier, bulk of the work is getting across the lesion. Now, of course, there's work afterwards as well, but there's a degree of cost effectiveness that we certainly pay attention to. But CTOs, planned atherectomy, anything in which I need an over-the-wire system, and I know I need an over-the-wire system. But by and large, it's those 2 groups of patients: CTOs, planned atherectomy, and then the STEMIs, just because often our techs on call are not all of them can quickly get the room set up. But otherwise, and I've noticed this for years, the moment we regularly do robotic cases, everybody gets on board pretty quickly, and the staff are on board pretty quickly. So I almost would say it's not who do we do robotics, we just identify the ones we feel are not optimal for robotics, and everybody else we try and do robotically. And I'll show you some cases here.
I'm sorry, I have one more question. How is its presence in non-cardiac vascular cases? For example, long intracranial cases or AAAs or peripheral cases?
So that's one of I did. If I have time, I'll be happy to show you the data. But we did do a study called RAPID, and then we did RAPID 2. We did it in Austria, where we did 2 sequential studies in femoral popliteal lesions and showed that it works highly effectively, safely, and that led to FDA approval for a peripheral indication for the robot. So this was for fem-pop lesions. And then we have subsequently done below the knee lesions, and that's been successful. And there are people that have also reported renal interventions, and there is work that's ongoing around carotid angiography and carotid stenting. I do not know of any work for AAAs, primarily because it's an 035 platform for AAAs, and this particular robot, you can use 014 and 018 wires in it.
Yeah, the carotid will be great because it's very easy procedure. Once you deploy your filter, it'll be very straightforward to do a balloon and a stent with robot. Dimitri, what are your thoughts?
Yeah, thank you very much, Dr. Mahmoud, for this great presentation. I'm really impressed. I'm aware of your papers about, and I'm very eager to see the cases. But one of the most important things is that I'm impressed that you need only, let's say, roughly 20% of the cases needed to have manual assistance. For me, this is a great number. This is really great. 80%, you can do it all alone with the robotics only. That's really impressive. And this is something that shows us the future. And the other thing, which is I would like to comment on, and it's very much relative to the peripheral cases, is that remote proctorship would be a great idea for using the robotics. Here in Ioannina, we are trying, in my university hospital, we're trying to set up an acute stroke service. And we are thinking what we're going to do if a case will be difficult and someone has to assist us. And as we talk about acute stroke, it's something emergent. So you cannot have the proctor beside you at the time that the stroke comes in. So I think that having a system like a robotic PCI, and given that this system may work even better for the peripherals rather than the coronaries, I think it would be a great idea to start thinking using a kind of service with different hospitals and working with the robotics to assist us in these difficult cases. I think for me, it's really an impressive thing, and we need to start working on it more and more. Thank you very much for that.
No, thank you for those comments. And actually, the 80 to 82% success was with the CorPath 200, the first generation. With the GRX, that's improved to 90%. So 90%. You're right, 90% technical success. And I think we're all very pleased with that, especially with guide catheter control. Talking about peripherals, especially the femoral popliteal segment and renals and carotids, yes, because they're not moving, it's even easier to be able to work. It's more the limitation on the peripheral platform, frankly, is the equipment, not the technical aspects of the robot, because a number of the self-expanding stents, for example, come in an over-the-wire platform, except for the carotids. And so an over-the-wire platform cannot be delivered with the current generation system. But that is all work in development. And I think over the next few years, we're going to see the ability to do more broad types of patients. And finally, your comment about remote, both proctorship as well as remote direct supervision. I think these are both areas that will develop pretty rapidly.
So there is a question from Professor Javian from Poland that what is the learning curve to do robotic PTA for FemPop just for a regular interventionalist doing conventional balloon and stenting?
Got it. Great question. So the question of learning curve broadly for robotics, it's a fascinating question because initial approval, and the FDA gave this, is you only need to do 3 cases for the coronaries. And I can tell you that is not an appropriate number. And we have looked at, excuse me, and what we have looked at, our data is at about 20 to 25 coronary cases, your learning curve plateaus nicely. Your case times go down, contrast utilization goes down, et cetera. So I think it's about a 20 to 25 total cases for yourself and for your team. Now, from peripherals, we actually have not done any formal study to try and sort out what the learning curve would be, but I would extrapolate and say it's likely very similar. It's easier, but it's, I would still say there are all kinds of simple things you learn whenever you're using this platform in the beginning.
Great. Well, I'm glad that Dr. Javian asked this
Can I
question.
do just
You know.
a very short question?
Yeah.
Very short. One of the most important things in our procedures is the tactile feeling. Can you feel with the robotics? Can you have this same tactile feeling using the wires or the catheters?
Sure. Another great question. So I always say I've been working with fellows. A lot of us have been working with fellows forever. So my tactile is really my visual. And before they do some of those things, I can tell. And when they do it, I can definitely tell. And that's how you are with the robot. You will not have tactile feeling, but you'll be surprised how well your own mind is able to recognize before the guide catheter starts to get pushed out, or before you're having some resistance with the wire. So you don't have tactile feel, but you start to recognize other visual cues on the screen.
Okay, it's like supervising your fellow working in the cath lab while you are outside.
Correct. And that's how it feels. The robot becomes the fellow.
Dr. Mahmud, should we go on and have you do some additional comments that you wanted to and show some cases?
Absolutely. So I will just show a little bit of the data, which is a few more slides, and then I will switch to cases. So let's keep talking for a moment, and let me go back and open up that presentation, and then I will.
While Ehtisham open up his slides, how is your experience with robot at Grady?
So we're early in our experience with the robot. As you know, Grady Memorial Hospital in Atlanta is one of the largest hospitals here, and it is basically a critical access hospital in this city. The robotic program there is much smaller than what Dr. Mahmud runs, for example. But we have been doing some cases. We've done some cases in conjunction with atherectomy, somewhat further down in our experience. We've done balloon angioplasty and stenting, obviously. So yeah, we've had good experience with the system, and it's been good for us.
Great. 2 years ago, we were going to do a live case from Grady. That's when the COVID hit, and we missed it. Hopefully next year.
All right. Can everybody see my slides?
Yeah, we do.
Perfect. So I'll quickly just finish up. This is, I mentioned the RAPID trial, where we looked at evaluating robotic interventions in the peripheral vasculature. And it was a prospective single-arm study with the CorPath 200 system. Here's the most complex case we treated, FemPop. We were able to wire it, balloon it, put a self-expanding Terumo stent. We treated 90% Rutherford 2 or 3. Average lesion length was just over 3 centimeters. And so in 20 patients, we had 100% technical success. There were no device-related adverse events, and this actually got approval from the FDA for using this platform in the periphery. Here's a case that we published for below the knee, and again, contralateral approach, down with a balloon angioplasty only. This was not stented, but this potentially could have been stented because it was just below the knee. So if we needed to, we could have put a balloon expandable DES, but this was using an 014 platform. We followed RAPID with RAPID 2. RAPID 2 has now been published and showing that if you look at the radiation exposure, this is an important point. In the original PRECISE study, it was shown that the radiation reduction was 95% for the primary operator. In this study, what we wanted to look at is what about the person who's table side? whether it's a tech or a fellow who helps you change the catheters and has to be table side for the angiography, et cetera. And you can see that the robotic operator has 97% radiation reduction, but the table side operator has 95% reduction. So I've already gone through this, but aside from the precision studies, what you can also see is the robotic peripheral vascular intervention is safe and effective with 95% reduction in operator radiation exposure. And the rest I've already talked about. So I will now let people talk and find my next presentation of some cases I would like to share.
Sure. So we have some comments from India. Gautam, I'm gonna give you this comments as you and Ahmed both are on ACC administrative councils. That in India, they charge an additional fee for having a robotic treatment. And here in US, CMS has not recognized robotics as a additional code. And if we are going to proliferate this technology to outpatient centers, which I think would be a perfect device to have in an ambulatory surgery facilities where we do a lot of vascular procedures, where there is not that much rush, and we are doing these cases very nicely. That would be very beneficial. Ahmed, you've been on some of these councils. Have you thought about bringing a robot to Egypt?
Yeah, I would love to. Maybe because I work in the Heart Institute, which is the biggest cardiac center, and it's for research. And so I think from the point of view that we should have such equipment in our lab, but practically in order to make such thing available in other facilities, I think the cost-wise and the training that it needs is a big challenge. I mean, I'd like to have it in the Heart Institute because it's a leading in cardiology. If Mahmoud agrees to visit us and supervise by himself such thing, but practically the cost-wise, I don't know. Did you do that in Pakistan or in India, Mahmoud?
I think the cost issue is obviously a huge issue, but I think what would be really neat to show and demonstrate is if we can get the remote developed, then just like we're giving this virtual meeting, I see no reason why we would not be able to do virtual supervision and cases robotically from around the globe. That to me would be really an amazing opportunity.
I was very lucky. I actually was part of the first remote case that was done by Dr. Tejas Patel in Ahmedabad, India. In fact, it was during the India Live meeting, and I participated from the other end. And it was a phenomenal demonstration. So I've actually seen it being done, very impressive. But I'm very interested in seeing these cases, and I know that a lot of our participants, we have many participants have joined in from across the world on our live on the Facebook, and lots of people have sent many comments. So everyone wants to see cases. So let's spend the remainder of our time on these cases.
Sure. So I'll share some cases. I'll go through them relatively quickly. Within complex cases, I've started with relatively simple ones, and I'll go into more complex ones as I move along. Feel free to interrupt or talk, or if anybody has questions, we'll stop. So starting off with a long lesion, here's a long mid-LAD. The point I wanted to make was this was very easily wired and stented, but this is the point I wanted to make. One of the big advantages of robotics and the robotic platform is you can move the balloons back and forth literally by a millimeter at a time. Trying to do that manually is not so easy. So when we're doing post dilation and just getting off the very edge, you can get very precise placement of that balloon. So this is a mid-LAD long lesion that was treated robotically. Here's one, an ostial LAD, and precise placement of the stent to just the ostium so it doesn't come back into the short left main was the issue. So it's wired robotically. Here's the stent positioned right at the ostium. And to make sure that the stent did not end up in the left main and the guide catheter didn't get sucked in, what I was able to do is both with advancing the stent and pulling the guide catheter back robotically, get the positioning optimally. And part of the reason I'm showing you these is early on, there was a lot of concern. Oh, you can't do ostial lesions robotically because you can't precisely place it. And same goes for long lesions. Here's one. What about bifurcations? This is an OM circ bifurcation. So I'll show you the steps, how to do this robotically. So wire in the OM, wire in the circumflex itself, balloon dilation of the circumflex, cutting balloon in the OM. And now the question is, okay, we want to stent the circ. This is a fluorostore showing a long stent being advanced into the circumflex. So as you can see, that was very easy to position. That's deployed. But I wanted to be able to dislodge this balloon from the stent. So advance the balloon robotically, dislodged it. Once it was dislodged, then it was very easy to pull the balloon back into the guide catheter. But now we have a wire that's trapped under this stent, and I want to post-dilate the circ. So before post-dilating, so the deployment was at moderate pressure. We want to do high pressure in the circumflex, but there's a wire that I did not want to entrap. So this is now taking the trapped wire out from under the stent, pulling it back into the guide. And this is re-advancing this wire through the stent back into the OM. And you can see it kicked out the guide catheter, but we were able to advance the guide catheter, re-engage it, post-dilate the circ, and that's our final result. So the steps are exactly what you would do manually. It just requires you to take the wire and move it back and forth between the side port and the robot driver.
Mahmud, there is a question from India from the audience. Yes. That primary wiring of majority of these lesions, are you doing that with the help of a robot, or are you manually putting the wires in?
100% with the robot.
And the second part of the question is, how do you feel is the movement of the wire with the robot comparison to a manual torquing?
So it works. Think of the robot as an extension of your own hands. Whatever you are able to do, you learn how to have the robot do exactly the same. And I've noticed that with other operators, people who wire a certain way manually, if anything, the robot helps you kind of standardize the wiring technique. So here's a case, a multi-vessel. You can see it's a tortuous right coronary artery, and on the left side is a distal left main, as well as a distal LAD. So I first tackled the RCA, and it is an Amplatz guide, wired it, distal balloon, mid balloon, distal RCA stent, but getting that relatively short stent to the distal RCA was not easy. And there was the stent in the mid RCA was going to be a little longer. So I'll show you what I did. So this is kind of a technique that I've been doing for years with the robot. And it's very much like what you would do manually. Sometimes we rapidly move our hands back and forth as we're trying to advance the stent or balloon, but often the stent. And so with the robot, I rapidly oscillated the delivery back and forth. And you can see it sort of snaked its way down to cover that mid LAD. So that's the final result for the RCA. Then we switched over, did the left, distal LAD, left main into the prox LAD. So that was a complete revasc on this patient robotically. This is probably the most complicated case I did robotically in the early days. It's a 43-year-old. I live in San Diego, California. This is a famous Hollywood movie producer who didn't believe in interventions. So had a diagnostic cath just a few days before, had high-grade RCA and left main disease, but left for chelation therapy. Showed up in cardiogenic shock. And so we first fixed the RCA because he had an inferior STEMI. This was done manually. So here's what the RCA looks like. Everything went well. Then we brought him back to the cath lab a few days later. He has a distal left main. He has a mid LAD subtotal occlusion. And I was actually doing this as part of a course, a teaching course about robotics. So let me show you. Here's the wire. I'm trying to get this wire through the mid LAD onto the LAD, but it was tough. It kept going into that diag. Eventually, I was able to get it through into the LAD, but look at the tip of the wire. We just wanted to highlight how I have good one-to-one control. This manipulation, by the way, is all with the robot. Nothing is manual. So we got the wire down the LAD, dilated, and you can see this distal left main. There's an ostial circ and prox diag. And I have a wire down the second diag. Stent mid LAD. And after this stent, the fluoro puff shows that that diagonal actually has an ostial proximal dissection, probably from when I was trying to wire it. So we took a third wire and wired the diag and pulled out the original wire, balloon dilated, still wasn't happy. So now what I did is I have a backstop balloon in the LAD and a stent in the diag. This part, I went to manual. Once I stented that and ballooned the backstop balloon, then we went back to the robot. So that's our kiss at the second diag LAD. Stented the distal LAD, placed wires in the first diag and circ, and then we have a long overlapping stent from that mid LAD back to the ostium of the left main. And this was definitely stressful because I was doing it as part of a live course, but it all worked out very well. And so we were able to do essentially the whole case robotically, except for that provisional stenting I needed to do for the second diag mid LAD bifurcation.
We have a question, Dr. Mahmud, from the audience about, do you do IVUS or OCT with a robot?
Good question. OCT, no. IVUS, the only IVUS that I've been successfully able to use is the Volcano Eagle Eye. Most of the other, the Boston Scientific IVUS, for example, gets crushed in the robotic delivery system. So I think currently, in general, IVUS is not a good thing to utilize robotically.
There is another question from the audience about your previous case of the circumflex and an OM bifurcation is why you did not choose to put a stent in the OM branch?
It had a residual stent.
Quite large.
Yeah, it was large. My plan up front was to do a provisional approach, and it had a residual stenosis that was less than 50%, and it wasn't a dissection or any compromised flow. All right, so this was a tricky case. It's an anomalous circumflex off the right coronary artery. So we wired it robotically. We're trying to advance the stent robotically, and you can see it prolapsed out the guide completely. Unable to do that. So then we were able to position a guide liner. Once we positioned a guide liner, then through that, we were able to stent this anomalous circumflex off the RCA ostium. And I'll finish with probably the first Impella-assisted robotic PCI ever done. I've done about 15 of these cases now, but this was the first one I ever did. It's a 59-year-old dialysis patient, post-CABG, all grafts are down, all native vessels are occluded. She has a distal left main. So we placed an Impella, and here you can see the distal left main bifurcation into the circ. We felt the circ system was pretty small, but I didn't want to lose it. So that's a balloon angioplasty into the circ. Angioplasty of the distal left main into the LAD with a non-compliant balloon. So we felt that it yielded well. Distal left main stent into the LAD. Post-dilated it. And that's our final result. And this went very smoothly, very well. And like I said, we've done a number of Impella-supported high-risk PCI cases robotically. All right, I think I'm finishing with a couple of minutes to spare. I just wanted to show a series of cases from relatively straightforward to more complex cases that can be done robotically, and we have done successfully robotically. Virtually entirety of these cases that I've shared was done robotically.
There are two questions from the audience. There's one question from Japan. What is the largest size guide catheter can you use with a robot?
Good question. It doesn't matter because it's the TUI at the back end that gets into the system that holds it in place. So, you know, you can use 6, 7, 8, whatever you need.
Yeah, just in Japan, you know, the 8 French guides are very popular, especially for the CTO work. So I suspect.
Raj, to answer that question specifically, we have actually used the 8 French guide system with the robot. It works beautifully. Our default is always a 6 from radial, but we've used the 8 French from femoral without any problems.
Yeah, and the other question from the audience was that when you have 2 wires through a guide in a robotic system, you know, is there been cases of wire meshing with each other or wire getting twisted over each other? Because in manual bifurcation cases, sometimes that is an issue, especially there is a lot of manipulation of stent in the balloons to try to push things in, and sometimes the wires sort of tangle over each other. So the question is that something that's better with a robotic system?
Yeah, I'm not sure it's better. It can absolutely happen robotically as well. One thing I will mention is it's a really neat, so with the current generation system, there are now a series of software, I'll call them upgrades. Let's call them upgrades. Different things you can do. One of those options is called ROR, rotate on retract. So what happens is you can choose to use it or not use it. But if you activate it, which I virtually do in all my cases, when you move the wire back, anytime you retract it, it automatically spins 15 degrees. So you move it back, and when you advance it, it automatically rotates 15 degrees, and you can keep doing it in that manner back and forth. And the idea is that if you keep going into a particular side branch, when you move it back, the wire automatically rotates, and when you re-advance it, it'll avoid that side branch. I would envision that maybe that technique would help decrease the likelihood of entanglement, because when we do it manually, sometimes we over-rotate beyond you know, a full 360 degrees. But I think my short answer would be I have not noticed a difference when I'm using multiple wires with the robot versus manually. And bulk of the cases, it's not a problem.
And this could be both for you and Gautam. A question from audience about potential for air. that how do you backbleed the Y connector, and is there increased incidence of air embolism with robot use?
So we have not actually had an increased incidence of air with robotic use. And if anything, and Shami can obviously give his opinion as well. If anything, the way the whole system is encased within the tubing coming out from the GRX, and with the TUI there, and the robot at the after you load the balloon and the wire and the stent on the system, you're really not introducing air into the system in any way, shape, or form. And given the fact that this is above the level of the wrist, usually, even if there is some leakage or bleed back, it tends for the blood to come out rather than for air to be drawn in. What is your opinion?
I completely agree. And I would say, and I remind people, the robot is an extension of your own skills. So good interventional practice doesn't change. So you would bleed back just like you do in a manual case. So if you are exchanging a series of devices, you flush and drain and bleed back just like you do in a manual case. And if all the skills that we have as interventional cardiologists and all the good practices, as long as you maintain them, there's no reason why you would have any higher risk.
We're pretty much out of time, but I'm going to take one more question for you guys from the audience about the peripheral procedure. In peripheral procedure, have you used robot to advance a contralateral diagnostic catheter or a sheath?
Yes, very easy to do so.
Okay, I think that, I pretty much addressed, there's a few other questions, but I think I pretty much addressed some of them were duplicate or similar concepts. I think that we have taken almost all audience questions. So I'll open up for any final comments from our panelists before we close.
So thank you for a fantastic presentation. Really, really interesting, and a great number of cases that you did. One question I'm wondering is that what time perspective do you think that you can foresee when we will be using this type of system in very complex lesions where you are able to do things that you're not really able to do as well manually? In other words, like in robotic surgery, they sometimes, you can do better precision surgery in some aspects. Will you see this with the robotics PCI, and what time perspective we're talking about?
I think we're at a spot now where clearly, 4 or 5 years ago, people used to ask me, how do you pick which case you can do robotically, and is it safe? And all of us like the visceral feel and the tactile feedback, and I think we've gotten beyond that point. It's safe, it's effective, and it can be used broadly by multiple operators, the robotic platform. I think at this point, the technology has to get better. And it's exactly the analogy I often make is the iPhone. Well, when I first did my first robotic case, it was 2013. Here we are 8 years later. And I can tell you the iPhone has iterated many-fold greater. And of course, they have many-fold greater resources. But I think if the technology continues to improve and get smaller, it needs to get smaller. It needs to get more facile. The switches, the changes between our different delivery, like balloon, stent, et cetera, has to improve. So I'm going to guess that it's going to be at least a 3 to 5 year minimum further time of development. But that development is not us as interventionalists. I think we're ready. I think it's the field the technology has to improve. So it's however fast Siemens can develop the technology, I think we can adapt to it.
So, Ehtisham, I have one question. So, when you compare it to what's going on with autonomous driving, etc., the machine learning plays a huge part. Are they taking each case and taking the data, adding it to their data set and using machine learning algorithms to improve the results or no?
Yeah, again, very good question. And I believe that's where Siemens is headed with this. And I actually just got an invitation yesterday about a meeting that we're going to hold on the East Coast in the next few weeks. So you've hit the nail on the head. I think the technology has to get better, but we can all envision how much we ourselves learn every time we do a case. And so if you could take all the learnings all of us have and magnify it, then in a particular lesion, in a particular situation, where this robot could give us a lot more value is give you options to say, well, in this situation, consider A, B, or C versus all other options. And I think ultimately that could help us standardize the field. So low volume operators, it should improve their quality of healthcare delivery and interventional cardiology. High volume operators, I mean, it doesn't matter. I think we all improve. The more you do, the more you think about it, and the more feedback you can get, you will continue to improve.
Well, thank you very much, Dr. Mahmud, for your wonderful leadership and a great presentation. You know, I think every one of us are thinking about talking to our hospitals to try to get the robot in. After seeing your cases, I'm super excited myself. This is going to be an evolving field. Our next webinar, again, is going to continue on the theme of robotic PCI. With that, I want to thank all of our international participants. We have 8 or 9 different countries, some of them extremely late in the night, but they've taken a time out of their schedule and their families to be part of this hour session. Thanks from everybody from US and all the panelists. We really appreciate and have a great rest of the weekend.
Thank you very much. Appreciate it.
Thank you very much. Bye.
Thank you.
Have a good weekend, everyone.
Have a nice weekend.
Thank you,
Thank
Shami.
you.
Thank you very much.
Thank you very
Cheers.
much. Take care.